Welcome, everybody. This is Terry Deeds, and welcome to our webinar today. I'm going to give this just a minute or two to let people sign in because we're watching the numbers go up here. So give us just a minute. All right, I think we'll go ahead and get started. I know people will keep joining us. Welcome to our fourth webinar in our equity series. Let's Talk Perinatal Equity. Today, we're going to talk about understanding bias and how we're going to track equity progress in the Maternal Data Center for those hospitals in California. The first three webinars that we had were really focused on different baseline assessments and how one understands where you're starting from. And now that we've started a new year, we're actually going to now get into some of the nitty-gritty, and we're going to start with understanding bias and start working towards some of the interventions that are going to go along with this work. So thank you for being here. We appreciate it, and we will move on to the next slide. So I want to make sure we do the housekeeping. Our continuing education notice, if you are a nurse looking for contact hours from this webinar, please complete the evaluation that will be sent to you about 48 hours after this webinar. The BRN, for those of you in California, know that you have to attend at least 50 minutes of this contact hour in order to have it awarded. So we're trying to stay in compliance with BRN. So thank you so much for your attention. Next slide. So just some logistics. We have muted all attendees upon entry. If you would like to ask questions, please use the Q&A function and not the chat function. We will do our best to answer them while the webinar is going on. We have some people behind the scenes who are equipped, ready to answer those. You are welcome to use any of the slides in this presentation for any kind of educational purposes that you might have. However, if you modify any of our slides or you add any slides, please put your own institutional logo on it and do not use the CMQCC logo. We want to make sure that what we're presenting is stuff from us, and you are welcome to add your own slides with your logos, which is perfectly fine. We do welcome your feedback and recommendations for improving future webinars. We're trying to meet the needs of all of our California hospitals. So thank you so much for your attention. Next slide. So our objectives for today, we want our attendees to leave with the understanding of the connection between clinician bias and quality and safety in your organization. How do you identify biased provision of care in your setting? And can we begin to gain a knowledge of tools to address it? We want you to be able to identify tools available in the California Maternal Data Center to track progress on your interventions to improve equitable care in your organization. Next slide. So the webinar recording and slides, as usual, will be posted within 48 hours on our website. And this is the link to that, where most of you know where to find them, but you will have the slides and the recording separate, so you can either flip through the slides or listen to the recording again, or send it to somebody in case you missed it. Next slide. All right, so today's presenters are very familiar to you. So we won't go into lengthy bios on these esteemed individuals, but we're going to kick off with Dr. Amanda Williams, who is an obstetrician and has a master's in public health. She has worked for many years in the Northern Kaiser system and really has led a lot of their efforts around equity in healthcare in that organizational system. And she's turned her clinical attention these days to really focus on equity and how we can really work on improving outcomes for some of our marginalized populations. She is currently serving as CMQCC Clinical Innovation Advisor and is one of the facilitators for our learning initiative to support vaginal birth through an equity lens. And so we are thrilled to have her, and she's going to kick us off, followed by Krista Sikowski, who is one of the clinical leads at CMQCC. She's my other half. Krista is focused she is also one of the facilitators of the learning initiative, as well as running our sepsis collaborative and community birth partnership. So many of you, I'm sure, have worked with her in the past, and we are thrilled to have her here to really talk about the Maternal Data Center and how we can help you track equity efforts. Next slide. And I'm thrilled to introduce Dr. Williams, and I'm going to let her take this away.
All right. Well, thank you so much, Terry, and thanks to everyone for being here and being part of what we're trying to do with CMQCC across the state of California to make a dent in maternal health inequities. The truth of the matter is that we didn't get here by accident. What we are facing is the downstream consequences, is a product of the downstream consequences of a lot of policy practices, et cetera, in the United States. And so we're going to go through that and think about how this shows up in our work on labor and delivery units. Next slide. So like most of our webinars, we do pause for an inclusive language notice. You'll hear me say birthing people, you'll hear me say mother, maternal, they, she. We really want to cast a broad net and recognize that all people who become pregnant and give birth do not necessarily identify as mothers or women. So we want to be sure that we are creating space for all of them and for all of their families, because we all need support. And what matters is how that birthing person is defining the key people for them. Next slide. And then in terms of disclosures, you guys have heard from me almost anything maternal health equity related, I'm interested. And so I am also the medical director of Mommy, which is a tech-enabled pregnancy and postpartum wraparound services company aimed at elevating maternal health equity and filling in the gaps of traditional prenatal and postpartum care. And then an advisor at Risk LD, which is an obstetrics alert and decision support software that aims to take some of the bias out of decision-making with fetal monitoring. Next slide. All right, so some of us forget sometimes that ending racial disparities in California maternity care is actually part of the CMQCC mission. We often speak of ending preventable morbidity and mortality, but those disparities are part of our essence, are part of our identity. So we don't want to think about health equity as add-on work or an additional effort that's being made. We want it to be part of our foundation, part of our core. And I love using the low-dose aspirin flyers for our low-dose aspirin project to remind us that this is how we do it, with this quality improvement work, by picking projects that are aimed at populations that our community has marginalized, our country has marginalized, and doing targeted outreach, lifting up community. This is how we're able to tick off all three: morbidity, mortality, and disparities. So this is just a quick example and a reminder that from its inception, from the mission, addressing racial disparities is part of what we do at CMQCC. Next slide. So, what is the problem we are trying to solve? Next slide. Now, unless you've been under a rock, you know that there are a huge maternal health crisis in this country, and it disproportionately impacts birthing people of color. And indeed, you may have seen me show this slide before, but the one piece of it I want to really pause on today is that image. Now, this of the painting it was done in the 1950s to elevate and celebrate the work of J. Marion Sims, the father of gynecology. But let's think about that for a moment. That work was done to elevate the efforts that are being made at the expense of the women that he enslaved, of Betsy, of Lucy, of Anarcha, who had scores of procedures and surgeries performed on them without their consent, without anesthesia. There's no way that that could have been okay, even for the time. There's no way that we don't see that that pain is being suffered. And so when we talk about unwinding the inextricably linked systemic racism and practice of OBGYN, this is a real body of work. This is a real effort. And it didn't get here by accident. This was very much embedded in the practice of medicine. Now, this isn't isolated to the 1840s when these procedures were taking place. We know that even published last year through the Stanford School of Economics and CMQCC, that when income and maternal deaths were matched, that at the highest income levels, both maternal and newborn deaths were double for Black families when compared to their white peers. So this history has a long tail, and we're still living with it today. Next slide. Now, it's not just death, right? We want to do more than have our patients survive, and not dying is not really an acceptable bar. But let's look at the mistreatment that is happening to our patients. We are not treating everyone the same, though that might be our intent. Far, far too many patients are being mistreated, and it's happening across the board. So this is a fundamental issue with how we are treating our patients on labor and delivery. And though we, our colleagues, our nurse, physician, midwife colleagues have the best intents to try to do right by patients, that is not what they are experiencing. And it's particularly not what they are experiencing if it is a woman of color or someone who is publicly insured or with no insurance. So there really is a body of work to do. Next slide. And the connection between mistreatment and maternal death is tighter than we might imagine. Care experience, positive treatment is not just a nice to have, it's actually associated with better safety outcomes. If you feel cared for by your nurse, if you feel seen by your midwife, if your doctor is actually listening to you, then they're going to be able to key in on symptoms that might be subtle, that patients might not have the actual medical language to speak. And yet it's critical that we're actually hearing our patients in order to get them the care that they deserve. This is particularly important when it's a time when we're not thinking clearly, when it's busy on labor and delivery, when we're woken up at 2 o'clock in the morning to hear about a patient complaint, when the staffing is less than optimal. And how often is that the case? How often are we running in a million different directions? Like every day, practically. So this is a body of work that is not just about care experience, is not just about the nice to have, make people feel good. This really is associated with severe maternal morbidity and mortality. Next slide. And we can't be lazy in California. We're just way too diverse. We can't just do a one size fits all because we have so many different races and ethnicities in our state, and we're huge. 1 out of every 8 babies in the United States is born in California. So this is a body of work that we have to do if we're going to be able to keep our moms and babies safe. Next slide. And I know that you've seen me show this before, and you know that it is the slide that wakes me up and gets me going every morning, knowing that my work is not done. Our work is not done. And thank you for taking it on for your organization, for your hospital. Because though California has the lowest maternal death rate of any state in the United States, these disparities are still unacceptably high. And we can't forget our Indigenous sisters also, because their rates are similar, if not worse, than that of Black birthing people. So when we're looking at maternal death rates compared to their white, Latinx, Asian sisters, our Black and Indigenous birthing people are still dying 300% times more frequently, and that is not okay. Next slide. And then this slide from CDPH reminds us of the different causes of death by different races and ethnicities. The other thing that it reminds us, and it makes my hair stand on end every time, is that this scale number here of 1 to 3 for Black birthing people, there's so much death of Black mothers in California that it doesn't even fit on the slide. Like, that is not okay. And so where are the spaces where we see the most loss? We see it in cardiovascular disease, we see it in infection, we see it in hypertensive disorders, in thromboembolic disease. There is so much loss, and so much of this is preventable. So thank you. Thank you for engaging in the work. Next slide. So a quick reminder of what is health equity. Next slide. And it is not I treat everyone the same. That is not what we are trying to do. We are trying to have a quality of outcomes, not a quality of treatment, because what each individual might need to get to that same excellent outcome might be different. And so we have to assess, we have to figure out what does each population need in order for them to have an affirming safe pregnancy. Next slide. So how did we get here? How did implicit bias get created when we have all these doctors and nurses who want to be doing the right thing? How did we get to this point that we are shooting ourselves in the foot and not being our best selves as we take care of patients? Next slide. So the concept is around inherited disadvantage. So we're not talking about a specific genetic polymorphism. We're talking about the downstream generational consequences, the intergenerational population health impact of things like discrimination, of segregation, of environmental racism, and how that then moves into a combination of lack of opportunities, lack of supportive environment, and then also toxic stress and the epigenetics of the concept of an allostatic load that is disproportionately borne by communities that have been discriminated against in the United States. And then we see the clustering of these chronic conditions, of obesity, of asthma, of diabetes, of hypertension. And all of those things are impacting that set of DNA that we are born with. There's more and more attention that's being paid to social determinants of health or health-related social needs, depending on whose terminology you're using. But our physical and structural environment in which people grow, learn, work, play, pray, has a very significant impact on their health. And so much so that now both the Joint Commission and CMS have identified that we must assess our patients during pregnancy and assess all hospitalized patients for health-related social needs and start to have resources to share with those patients. Next slide. And then let's get more granular. Like, how really did we get here? We can say that there was enslavement. We can say that there was Jim Crow. But how does that really get us to this place of bias? So let's think about things like education. So when so many folks came back from World War II, and we're coming back to then get an education and have the GI Bill to support them in those pursuits. Were those loans, was that education available to everyone? No, it wasn't. Black people were intentionally excluded. And y'all, we're not talking about a long time ago. We're talking about my parents' and grandparents' generation. This is not far. The Civil Rights Act, the Voting Rights Act, we're talking about the mid-60s. I'm not going to say exactly how old I am, but it's not that much sooner than when I was born. My dad was there on the March on Washington. This is not distant history. So we are really misguided when we think that oh, those are things of the past and that isn't relevant to what we're doing today. That's just not the case. Let's also think about the Federal Housing Administration loans and mortgages. Were those available to everyone? When people came back from the war, both in World War II and in Korea, many folks got their first house with those super low interest rate FHA loans. Were those available to Black people? No, they weren't. And then let's think about pink lining and red lining and how neighborhoods were used. Let's think about eminent domain and which neighborhoods were chosen to put freeways through, leading to higher or lower property values, leading to the denigration of neighborhoods, leading to lack of green space, and then eventually physical safety. These things are part of the history of America that has led us to this space. So these policies, these practices are very much a part of getting to these inequitable outcomes and racial disparities. And then how do we learn about how other people are living? When you are a white person living in the suburbs, you can make the choice to not have to interact with diverse populations. It's getting harder and harder, especially in a place like California, especially if you work in a hospital. Most often there are times that you have to interact with diverse communities. But what is it that you see on TV? What is it that you see in the movies? What do you see represented in the newspapers? Those biases come as those biased representations come as part of this history. And if the only people of color that you're interacting with are from what's on the radio, or people don't listen to the radio anymore, but on Spotify or on Netflix, you're going to have a very different view of the world. Next slide. So when we're trying to work against this, when we're trying to create a strategic framework for how to operationalize equity, we have to think about all of these barriers that have been put in place. This is the high-level framework of what I had the privilege of building inside of Kaiser Permanente in Northern California before I left a year and a half ago. And we have to take all of these things into account. We have to use the data. We have to be able to reliably measure and document what's going on. Fortunately, in California, you have the MDC, you have the Maternal Data Center to be working with to help you along this way. We have to be able to remove barriers. There's some things out in the community that we're not going to be able to fix. So you're not going to be able to probably plant a whole new park in a chronically disinvested neighborhood to be able to help folks have more healthy places for exercise. But what you can do is think about your visitation policy, and can patients go in and out of the hospital? That is a barrier that's actually within your control that can have a outsized impact for certain communities. Then we want to empower patients. All of those things that we saw on the slide before are part of chronic disempowerment. So we want to give tools to patients that are recognizable to them, where they see themselves in the images, where their language is being spoken, so that they can help be part of promoting healthy decisions. And then we want to get our clinicians, our staff involved. This shouldn't just be the administration making a decision and saying, okay, now we're going to be equitable. We have to ask our communities, get the feedback and engagement from our teams as well. Next slide. So where do we see bias showing up? And, I have to tell y'all, this does make me a little nervous because I am not a structural racism expert. I've spent a lot of time studying it, but that is not my expertise. But what I have done is spend a lot of time on labor and delivery units, on working on issues of equity, and thinking about how do we overcome biases in our workplace. Next slide. So I appreciate my colleague, Christine Morton, who shared this image of some of the ways that we see stigma and discrimination show up. We think about, when is drug use mentioned in HPI in somebody's note? When do they talk about race? Are all lab values being looked at? Are people being berated for no showing as opposed to asking what the why is for why they're not making it to the appointment? Are there delays in diagnosis and treatment? Are we looking at certain words in nursing notes around refusing to cooperate or not making eye contact or calling patients non-compliant? There are all these little hints, all of these little code words that we see. And in my work as a maternal death reviewer, this is some of the stuff that we're looking for when we're looking for evidence of possible discrimination happening in care. These are some of the behaviors and language that we're looking for. Next slide. And so drilling it, sort of giving a few more examples, I want to just go through a couple little stories of places where we see implicit bias show up. Because unless you're looking for it, then it might go past you. or you might not notice what's going on. My colleague, Dr. Jochen Profit from CPQCC and Stanford Neonatology, has done with his collaborators some really fascinating work on NICU visitation. So depending on someone's social circumstances, how they are showing up in the NICU might be seen very differently by the nurses. So one person might show up late and they might be given compassion, like, oh, I bet you had a hard day at work. Then another person might show up and like, ugh, why is she late? Why isn't she here to support her baby? Then thinking about skin to skin time, the research is showing that even when you're matched for actual number of minutes spent per week in the NICU for family visitation, those that are non-English speaking are having less facilitated skin to skin time. So what is it that's getting in the way? Are the nurses being biased against babies? No, I'm sure they're not intentionally trying to not give skin to babies. But if it's a little bit harder, if you need to use the interpreter, if you're not comfortable in your communication, then we're going to take shortcuts in those situations. We also, Christina Oldini, another one of my CMQCC colleagues, shared an example that in one of her former hospital sites where she was working, where before we went to electronic medical records, they had printed medical records that used to come in different envelopes. And the patients who were in the substance use program had a different color envelope than patients in the rest of the prenatal care population. How were people with those different colored envelopes talked about? What was the chat that was going on? What were the assumptions that were made based on the trigger of that different colored envelope? Then we think about the conversations that are going on at the nurses' station. And if you really want to know about the culture of the unit, spying on the nurses' station is a really good place to do it, to hear casual conversation and to hear what might be going on. Is there eye rolling going on or disparaging comments about someone who might be a grand multip? So there are lots of different places where we might hear bias starting to creep in. And then some of you have heard my own story about picking up a shift on labor and delivery. And now that I'm not while I ran the unit with my nursing colleagues for 10 years, I'm now just, an attending, taking a shift. And this new assistant nurse manager looked at me, looked at my colleague who we were standing side by side, both in our white coats with our badges and our stethoscopes and our scrubs. And she looked at him and said, "Good morning, Dr. So-and-so," and looked at me and said, "Oh, good morning, Amanda." And it's not that there aren't plenty of nurses who call me by my first name, but it's because we know each other and we have shared experience. And I asked the nurse later, was it because I'm a woman or was it because I'm Black that you called him Dr. So-and-so and called me, who PS hired him, and he is like 15 minutes outside of fellowship. Anyway, but called him Dr. So-and-so and called me Amanda. And she said, "Oh, no, that must be a mistake. I never call doctors by their first name." And I said to her, "Well, that's worse because that means you didn't even see me as a doctor." And so I'm sure that this assistant nurse manager is not running around with a bigot t-shirt on and certainly doesn't see herself that way. But there are assumptions based on this history of the United States that we live in that sneak into our behaviors, even when that's not our intention. Next slide. So how do we move beyond training and integrate what we know about bias into our maternal health equity efforts? Next slide. And so at CMQCC, bias has been incorporated and addressing bias into all of our current projects. So whether it's anemia or our community birth partnership or preeclampsia prevention, the mortality review, sepsis, postpartum redesign, every single one of these projects, we are segmenting data. We are engaging the impacted populations and community, and really trying to hear from patients how we are moving the needle in specific populations. Next slide. And then inside of the hospital action guide, hopefully everyone who's on here has accessed the guide. It is available to anyone with a California maternity hospital email address. The hospital action guide has so many tools available in order to take you through this journey. Next slide. And inside of it, you'll find more information about sort of where this comes from, the need for birth equity, how we use our data, how we work on patient experience and clinical outcomes, how you change practices inside your hospital, how you leverage patient processes and data to address disparities, how we create a culture of respectful care on our units, and then how we integrate community collaboration. So even if you're not part of the learning initiative at this time, one can certainly do a DIY, can pick and choose from this list in order to really start moving the needle inside of your organization. Next slide. And again, thank you to Christine Morton and to our colleagues who are part of our pregnancy mortality review committee. There are so many pieces of this, what's contributing to US maternal mortality. And really these arrows are two-way arrows because they all contribute. One of the things I would encourage folks to do is we see in the upper left structural racism and bias and discrimination, but then go through some of these other circles and think about how does the history of bias and discrimination and structural racism impact all of these other different pieces. Many of them are very tightly linked. So even though they're not in that one circle of racism or bias and discrimination, many of them are their downstream consequences. Next slide. So we would certainly encourage folks to get involved if you are not already doing so, with pilots, with local initiatives at your medical center. We have the data through the MDC to support you. We would encourage you to integrate some of this work into your recruitment strategies, into your collaboration with your community, into the ongoing presentations and invited speakers that are happening at your medical center. And then to keep going with this bias work. Many hospitals are 2 years from our original state mandated bias training. So we want to make sure that it keeps going. And then to think about how can we leverage technology in order to bridge some of these gaps. And again, even if you are not in the learning initiative right now, all of these hospital action guide tools are available to you. And we would encourage you to do pilots, to start the work at your medical center today. So that is it for me. I think I'm going to turn it over to Krista now, if you go to the next slide.
Thank you, Amanda. And I do want to apologize for not being able to be on screen today. I'm actually broadcasting from a labor and delivery unit in Southern California, and in an effort to maintain privacy of all the patients and staff here, I'm going to stay off camera. I do want to talk to you today, though, about the NTSV Equity Structure Measures tracking tool that is available to you in the Maternal Data Center that can help you along as you map out this work, complete this work, and think ahead about what implementation practices you'll be instituting on your units. Next slide, please. So this tracking tool can be accessed in the MDC, or the Maternal Data Center, by anyone with California Maternal Data Center access. So hospital MDC administrators or data entry status user types are needed to complete the checklist, but anyone with access to the Maternal Data Center could see the progress that your hospital has made on these structure measures. Next slide. So what are structure measures? Well, structure measures are the capacity, the systems, and processes to provide high quality care. And examples of this have been things that you've implemented in other collaboratives with CMQCC, things like physical equipment standardly used in care, like our hemorrhage carts, any policies that we put in place to guide care, and routine debriefing of cases. So structure measures are that other piece of data that we work on to map out our progress within any implementation project. And we match that with our outcome measures that actually shows us things like the NTSV cesarean rate. Next slide. So this is how you access the structure measures checklist within the MDC. This is the landing page for accounts. If you do not have an account yet, we have many user guides at CMQCC for how to sign up for an account. It takes about 2 minutes. Anyone with access to the MDC currently will already have an account and be able to access it this way. But this is the landing page in which you access that. So there in the middle, you see the Maternal Data Center box, and you just click on the Launch the California MDC button. Next slide. When you do that, it's going to take you to what we call your hospital landing page. This is a fake hospital that we use at CMQCC to demonstrate different modalities of the Maternal Data Center. So this is Alpha Medical Center, and all the data is not real. But you can see there on the right-hand side, under what we call the Birth Equity Dashboard, you see the NTSV Cesarean Equity Learning Initiative. So every hospital in California that's a member of CMQCC has access to this dashboard and access to these structure measures, regardless of whether you're actively participating in the initiative or not. So you're able to review these structure measures and start on this work, whether you are planned to be in the learning initiative someday, or currently in the learning initiative, or maybe will never be in the learning initiative for whatever capacity reasons, et cetera, et cetera. Next slide. So when you click on that, this is what next page is going to look like. And at the top, there are the equity structure measures. And this looks very similar to if you've ever participated in collaboratives at CMQCC. This is how we've always laid out all of our structure measures within the MDC, depending on what the implementation project was. So it's got that confirmed in place on date, and it has not in place. So sometimes some of these things, especially if when we get to the NTSV structure measures, NTSV specific structure measures, you may have had these things in place for quite some time. Maybe you can't remember the date that you originally implemented it, and that's not really the important part. You can go ahead and say, today is when we're starting this work on this implementation project, and we're going to go and re-review all the things that we think are in place, and just put today's date. You know, you could just put today's date is the day that we confirmed it's in place, and now we know and we've double checked. If it's something that you've looked at and you know is not in place, then you just click the not in place button. And the reason for that is that we kind of track on the CMQCC side how many hospitals are in process of implementing certain things, how many things have already been implemented, and it gives us an idea of how to structure support for California hospitals. What webinars should we offer? Are there any special resources that we need to develop? Does it seem to be that there's specific structure measures that hospitals are having a harder time or avoiding for whatever reason? So we ask that you do that, because when you leave it blank, what it kind of looks like to us on our side is that that issue hasn't been addressed or evaluated. When you click not in place, it shows that we have made that evaluation or that determination, and at this time, our hospital does not have that in place. Next slide. So there are 10 equity structure measures, and I don't expect you to be able to read these structure measures, and that wasn't my intention, but it was just basically to show you kind of what it looks like. Each structure measure is laid out with a specific goal in mind, and then below that you can see that there's a why. And the why is really provided to you so in case you are engaging in any conversations with stakeholders, administration, staff, and you really want to offer that support as to why implementing that specific structure measure is important, it kind of gives you that talking point. It can be overwhelming to take on this work. So we wanted to make sure that we offered a little bit of support there within talking points. Some of these structure measures have what we call sub-bullets or like different pieces associated with them. And you'll see, I think on the next screen or the screen after that, but you'll see what that kind of looks like when we have multiple pieces associated with the structure measure within the MDC. Next slide. There are 8 NTSV structure measures, and these are pretty aligned with the original C-section project. So if your hospital participated in that, it's very closely aligned with that, and they should look very familiar to you. And just the caution associated with that is that you don't assume that because you were a part of the collaborative at some point that these things are all hardwired and all in place. We did notice during and post-COVID that there was a slight uptick in C-section rates in the state of California. And we did get reports from many hospitals that some of these practices that they believe to be in place or hardwired at one time were no longer so. So we really do want you to make sure that you go in through these structure measures, even if you believe that they were in place, and just double check and make sure that the way that you intended for those to be implemented is in fact still implemented in that way and still working for your facility. Or maybe there's been some changes in the layout of your unit or other structures associated with your unit that makes that implementation practice the way that it was previously no longer work and it needs to be reimagined. Again, just like for the equity structure measures, you'll see the whys associated with all these NTSV specific structure measures. Next slide. So there's a couple different ways to look at this. So once you go through your structure measures list, and again, you can all get off this webinar and go do that immediately. You can fill in the things that you have in place and click the things you don't have in place. And then you're going to be able to look at that data or those responses in a couple of different ways. One is to go ahead at the top of that screen and click the performance trend. And you can see that red arrow there. When you click that, next slide. It's going to take you to a screen that looks like this. That's basically just a trend line to show you how complete you are with all of these implementation structure measures. So if you've got, you just start the project and you've got a few of them done, it's going to show that trend line. And then as you progress through the project, the goal is to have all of the structure measures completed or to reach 100%. Graphs like this, trend lines can be useful in department meetings. Anytime we're presenting some of our progress with an implementation project to a wider audience that might not understand the day-to-day work that's associated with the project or all the specific structure measures or what they entail, but it can document what the unit's progress is within that project. And in this way can maybe garner some support if you're having a hard time moving that needle and getting these things completed, or just kind of be an opportunity for you to brag about how far you've come in this project in whatever period of time. Next slide. Another way to disseminate and look at this information is to click that top PDF button. Go ahead and click. Next slide. And this generates what we call like a one-pager, a PDF report. And it removes all of those, the whys associated. So you won't have like as long of a page. You don't have to scroll through it. It's a one-pager. And it lists out all of the structure measures for NTSV and for equity throughout the whole project. If you've clicked not in place, you can see under that column where it says date completed, it clearly says not in place. If you click some of the sub-bullets, so earlier I said that some of the structure measures have sub-bullets, so they have pieces beneath them that need to be completed. And so this way, if you've worked on your policies and procedures, but you haven't reviewed any of your marketing and education materials, you go ahead and click off policies and procedures. You don't click marketing and education materials, and it shows that structure measure is in progress. So some of your sub-items are completed, but not all of them. And, you know, in hospitals, in medical environments, we really do like our checklists. It kind of keeps us organized. So this is just a way to keep us all organized with the structure measures and have a quick read of it. If all of your sub-items are completed, so that third arrow down on the page, it will ask you for a date that those sub-items were completed, and it'll show that as completely completed with the date and the sub-items checked off. And if it's just a structure measure that does not have sub-items, you're going to just fill in the date and it will show you the date filled in. So a report like this, again, can be useful to send around to administration, to bring to any larger quality meetings to really document and show the progress. And specifically, not just overall as giving you a percentage with the trend line, but showing exactly what you've completed within your unit and the things that you still have to work on, again, to garner support, restructure, allocation of dollars, et cetera, et cetera. Next slide. So if you have any questions, you can go ahead and drop those into the Q&A box. Additionally, I just want to let you know that we have open office hours monthly. The next session of office hours is going to be on March the 6th. In order to register for office hours, you just go through accounts to the hospital action guide. On the left-hand side of that page, you'll see open office hours. You just click that and you register for office hours, and Terry and I will see you there. I believe I'm passing to Christina.
Next slide.
Thanks. Hi, good afternoon, everybody. I see so many names that look familiar. Great job to my team, my colleagues here at CMQCC. I want to let everybody know we have a wonderful two-day conference coming up at the end of March. We want to be inclusive. Last year, we opened up a wonderful rate for doulas, for those in public health. So we know that the care continuum must be represented in any kind of education we offer. So please check out the event. It does get really, I have to say, it gets great evaluation, great scores. And again, please look at the rates because there may just be a really reasonable one that you can take us up on. They're great topics too, devoted to equity. So please check it out. Next slide.
Okay, thank you, Christina. In conclusion, we want to introduce you to another upcoming event. This is the CPQCC, which is the California Perinatal Quality Collaborative, our sister organization on neonatal and quality improvement efforts. They are running their annual Improvement Palooza coming up. This is a registration slide for that. It is being held virtually and live, and it's in Coronado Island. So, you know, can't do much better than a little trip to Coronado. But if you're very interested in that, it is coming up quickly on March 1st. So take your opportunity to register for that. It is focusing on roadmap to community engagement and neonatal equity and advocacy as they do the work in the neonatal section as well. Next slide. All right, I think that is concluding our presentations for today. We've tried and I believe answered all of your questions. I hope we got to them all. So we thank you for joining us today, and we look forward to having you join us in our next webinar, which will be in about 3 months. And thank you for your efforts and everything you do to help foster equitable care for the birthing populations in your organizations. Thank you for everybody's attention today, and we appreciate it. Thank you, everyone.